All right, let's talk RadBio. Specifically, how normal tissues react when they meet radiation.
Yeah,
This is really fundamental stuff, absolutely essential, whether you're getting ready for boards or just trying to be, the best clinician you can be.
absolutely. We're going to unpack the sort of building blocks of tissue response, things like functional subunits.
Okay.
Then we'll contrast early and late reacting tissues, and then really spend some time dissecting radiation-induced fibrosis. That's arguably one of the most significant late effects we deal with.
hmm
Knowing the players there, especially the molecular ones, is really key.
It truly is. I mean, this knowledge shapes everything from how we draw contours to how we choose fractionation schemes and ultimately how we try to minimize toxicity for our patients.
It underpins so much.
Okay, so let's jump right in. We often hear about functional subunits, FSUs, when we're talking about how organs tolerate radiation dose. What exactly is a functional subunit? Like, what are we picturing here?
Well, think of it as the smallest possible unit of a tissue or organ that can still do its job. And importantly, it can potentially regenerate if it gets damaged.
Regenerate.
Yeah, usually from surviving stem or progenitor cells within that same unit. It's like the little self-contained engine within the larger machine.
Got it. So not just any old cell, but a group of cells organized in a specific way that performs a function
Yeah.
and has that capacity for self-renewal.
Exactly.
And how these little engines are wired together, how they're organized within the organ, makes a huge difference in how that organ handles radiation, particularly the volume effect, right? We talk about serial and parallel.
Precisely. Yeah, serial and parallel organization. Imagine serial organization, like a chain. The functional subunits are the links.
Okay.
If you break just one link, even if the rest of the chain is perfectly fine, the whole chain is effectively broken. The organ function fails because it relies on that intact sequence. The classic, and frankly the one we all worry about, is the spinal cord. You damage one small segment at a high dose, and you can lose function below that level. Completely devastating.
Yeah.
Other examples, maybe less dramatic but still serial, are things like the optic nerve or hollow viscera like the esophagus, where you need that continuous tube function.
Right. So for those serial organs, there's a really steep volume effect. A high dose to even a tiny volume is incredibly dangerous.
Hugely dangerous.
The probability of a severe complication just skyrockets once you cross that critical threshold dose in any part of that chain. You can't really trade off volume for dose easily there.
Exactly. You can't compensate. Now, contrast that with parallel organization. Instead of a chain, picture maybe a bank of light bulbs, like in a big chandelier.
Okay, I like that.
Each bulb is like a functional subunit, and they're working more or less independently. If you lose a few bulbs, the chandelier still provides light, right?
Yeah, it's dimmer, maybe, but it works.
Exactly. The overall function is degraded, maybe less efficient, but it doesn't just stop working until you've damaged a really substantial number of those bulbs, the subunits.
So examples would be,
Oh, organs like the lungs with their millions of alveoli for gas exchange, or the kidneys with all their nephrons filtering blood, the liver lobules, the skin, the mucosa. Lots of examples.
okay, so in parallel organs, you have a weaker volume effect for partial dysfunction, let's say.
Right.
You can lose a certain percentage of your functional units and still have some level of function left. Clinical problems usually only show up when a much larger volume has been hit.
Correct. The dose response isn't that sharp step function like in serial organs. It's more gradual. It climbs more slowly.
Which is why for organs like the lung, we often look at constraints like B20, the volume getting 20 gray. It's about the total damage load across many independent units.
Precisely. It reflects that aggregate damage concept.
And it's probably not always purely one or the other, is it?
Oh, definitely not. Just to make things more interesting, many organs have elements of both. The lung is a great example. You've got the parallel alveoli, but the major airways, those function more serially.
Okay, that makes sense.
So understanding which component might be dose-limiting or contributes most to a specific side effect, that's key for planning.
Absolutely. Yeah, rarely black and white in biology, but classifying them definitely helps us think about risk and how we design our plans. So building on that foundation, functional subunits and organization, let's connect this to another really fundamental concept, the difference between early and late responding tissues. Why do some tissues react within days or weeks, while others take months, even years, to show problems?
Yeah, this is a really important distinction. It comes down primarily to cell proliferation kinetics. Basically, how quickly the cells in that tissue turn over.
How fast they divide and get replaced.
Exactly. Early responding tissues, think skin, the lining of your gut, bone marrow. They have a very active stem cell compartment. There's high cell turnover. New cells are constantly being made.
These are the H-type tissues, right?
Am I right?
Hierarchical.
Correct. H-type for hierarchically organized. They have that clear stem cell pool constantly churning out differentiated cells that do the work. And then those cells shed or die off fairly quickly.
So when you irradiate these tissues,
You hit the stem cells, you sterilize them, stop them from dividing. The existing differentiated cells, the mature ones, they keep working for a little while.
their normal lifespan.
Right. But as they naturally die off, there are no new ones coming up behind them to replace them. So the functional deficit, the clinical effect, like mucositis or skin reaction, appears relatively quickly as that pool of mature cells gets depleted.
Okay, so the damage reveals itself fast because the cells live fast and die fast anyway.
Pretty much. And the functional units in these early tissues, well, they're less rigidly defined structurally. But the key is, if enough stem cells survive in nearby areas...
They can migrate over and repopulate.
Exactly, they can repopulate the damaged regions. That's why acute effects often heal, sometimes remarkably well, assuming the damage wasn't overwhelming. There's a strong capacity for recovery through repopulation.
Okay, now contrast that with late responding tissues, like spinal cord, lung parenchyma, kidney, liver.
Right. These tissues have very slow cell turnover. They consist mostly of long-lived, differentiated cells that don't divide very often. These are often called F-type tissues.
F-type. Flexible or functional?
Well, the original models used F for flexible tissue structure, but the key is slow turnover, consisting mainly of functional differentiated cells.
Okay, so damage here. It's different.
Yeah, the damage here might be to those slowly dividing functional cells themselves.
Yeah.
Or perhaps more critically, to the supporting structures, the fibroblasts, the blood vessels, the connective tissue framework.
The infrastructure.
Exactly. These tissues don't have that rapid stem cell-driven renewal system, so the damage takes much longer to become apparent. It unfolds over months or years as these slower processes play out, or as that supporting framework gradually breaks down.
And the functional units in many of these late tissues, like you mentioned the kidney and nephron earlier.
Right, like a nephron. They're often more structurally distinct, more defined.
So if you kill the critical cells within that specific unit,
That unit is likely gone for good. It
That-
can't easily be rescued by cells migrating in from, far away, like you might see in the gut lining.
I see. So less repopulation potential.
Much less. And this lack of rapid repopulation is a big part of why late effects are often progressive, harder to reverse than acute effects, and also why these late tissues are generally more sensitive to the dose per fraction.
The low alpha-beta ratio connection.
Precisely. That's where it comes from. Their damage response is more influenced by the size of each dose fraction compared to early tissues.
So the Michalowski H-type and F-type models, they're simplifications, but they capture that core difference. High turnover, early effects, repopulation. Low turnover, late effects, less repair, fraction size sensitivity.
That's the essence of it, yeah. It's a really crucial framework for understanding fractionation effects.
Which leads us nicely into one of the most significant and often most challenging late effects we face clinically, fibrosis.
Ah, yes, fibrosis.
That excessive scar tissue formation that can harden organs and just destroy their function over time.
Yeah, it's a major dose-limiting toxicity for many sites, and it's not an immediate thing. It's a complex, drawn-out, chronic process.
Where does it start?
Well, it starts with the initial radiation hit, obviously. That causes direct cell killing, not just the main functional cells, but also supporting cells like endothelial cells lining blood vessels. Plus, you get generation of reactive oxygen species, ROS, causing DNA damage and cellular stress.
Okay, initial damage, then what?
That initial insult kicks off something really critical, chronic inflammation. It's not just a quick cleanup response, it persists.
No.
Macrophages and other immune cells are drawn into the damaged area, and they start releasing a whole cocktail of signaling molecules, cytokines, and growth factors.
And this is where certain molecules become really important.
Absolutely. And if there's one molecule you absolutely have to know for radiation fibrosis, it's TGF-beta, transforming growth factor.
TGF-beta, the
Alpha.
master regulator.
It really is. It's considered the master regulator of this whole fibrosis cascade.
Right.
It's produced by lots of cells involved, those macrophages that came in, damaged epithelial cells, endothelial cells, and radiation exposure significantly cranks up its production.
Okay.
And importantly, it's often secreted in an inactive, latent form. The radiation-damaged tissue environment actually helps activate it.
Okay, so radiation causes damage, inflammation kicks in and persists, and this inflammatory environment activates and stimulates production of a lot of TGF-beta. So then what does this active TGF-beta actually do that causes the scar tissue?
It does several really key things. First, it's a potent chemoattractant. It basically sends out a signal saying, hey, fibroblasts, come over here.
Fibroblasts, those are the cells that make connective tissue, right?
Exactly, the primary connective tissue producers. So TGF-beta calls them to the site of injury. Then it tells those fibroblasts not just to show up, but to proliferate, to multiply, and also to differentiate into a more activated, souped-up form called myofibroblasts.
Myofibroblasts. Okay, those sound like the real workhorses here.
They absolutely are. Myofibroblasts are like little factories churning out massive amounts of extracellular matrix components, especially collagen.
Collagen, the main component of scar tissue.
Precisely. Think of it as the structural scaffolding. Normally there's a balance matrix is laid down, but it's also broken down and remodeled by enzymes called MMPs, matrix metalloproteinases.
Okay, the balance.
But TGF-beta throws that balance way off. It directly stimulates the myofibroblasts to produce more collagen, and it prevents the matrix from being broken down. It does this by downregulating those MMP cleanup enzymes and upregulating their natural inhibitors called TIMPs.
Ah, so it's hitting it from both sides. More production, less removal.
Exactly. It's a double whammy. You get this uncontrolled, excessive deposition of extracellular matrix collagen, fibronectin, etc., which accumulates, cross-links, stiffens, and eventually replaces the normal functional tissue architecture. That is fibrosis.
And I guess ongoing damage, maybe from messed up blood vessels also hit by radiation, just fuels the fire.
Oh, absolutely. Concomitant vascular damage is a huge contributor. It's another well-known late effect of radiation. It can cause chronic ischemia, basically, a lack of oxygen in the tissue.
Which probably isn't good for healing.
Not at all. That chronic ischemia can further stimulate these profibrotic pathways and just perpetuate the whole vicious cycle.
Okay, so if we boil it down, radiation damage kicks it off. Chronic inflammation becomes the persistent engine. Sustained activation and production of TGF-beta is the central command signal. TGF-beta drives fibroblasts to become these hyperactive myofibroblasts,
Right.
leading to runaway collagen and matrix deposition, which is fibrosis.
That's a really good summary of the core cascade. It's crucial to understand that sequence.
Yeah, it seems really central.
It is. And, while TGF-beta is definitely the star player in fibrosis, it's not working alone. There's a whole supporting cast of other cytokines that are critical, especially in that initial inflammatory phase and the overall tissue response.
Okay, who else is important? Like TNF-alpha. I hear that one mentioned a lot. Tumor necrosis factor alpha.
Yes, TNF-alpha is a major one. It's a potent pro-inflammatory cytokine. It's typically released early after radiation by macrophages and other cells.
And what does it do?
It contributes significantly to the acute inflammatory reaction, think redness, swelling. It can also cause vascular damage, like making blood vessels leaky, promote cell death or apoptosis, and importantly, it helps feed into that chronic inflammation phase that ultimately drives the late effects like fibrosis.
So it primes the pump, in a way.
You could say that, yeah. It's involved early but has downstream consequences.
What about IL-1? Interleukin-1, another early one.
Correct. IL-1 is another principal pro-inflammatory cytokine, also produced by macrophages, endothelial cells, fibroblasts, often induced early on.
Similar role to TNF-alpha.
Very similar in many ways. It mediates classic inflammatory signs like fever, helps recruit white blood cells, definitely amplifies the overall inflammation. And again, like TNF-alpha, it plays a role in perpetuating that chronic inflammation needed for late effects to develop.
Okay. Any others we should keep in mind? IL-6.
IL-6, interleukin-6, yeah. Also, generally pro-inflammatory. It's often induced by TNF-alpha and IL-1, and it's involved in the systemic acute phase response things your whole body notices, not just the local tissue, contributes to the broader inflammatory state.
And what about growth factors? Sometimes you hear about PDGF or BFGF.
Right. PDGF, platelet-derived growth factor, is another molecule to know. It stimulates fibroblasts to proliferate and make matrix, so it definitely adds fuel to the fibrotic fire.
Okay.
And BFGF, basic fibroblast growth factor, is also involved in tissue repair and angiogenesis, building blood vessels. Its role in fibrosis is maybe a bit more complex. Sometimes it might even be protective for vasculature, but it's certainly part of the overall signaling network.
Wow.
The main point is it's a complex interplay, a real network effect. These cytokines aren't acting in isolation. They influence each other, creating this cascade that orchestrates the whole tissue response, from the very first acute inflammatory signs right through to those chronic late effects like fibrosis and organ dysfunction.
It really is a complex symphony, or maybe sometimes a cacophony of signals, isn't it?
That's a good way to put it. And understanding which instruments are playing loudest or playing out of tune helps us figure out what's going wrong and potentially how to intervene.
Which brings us right to the clinical relevance. Why does knowing all this molecular biology and tissue organization actually matter when you're seeing patients or planning treatments?
Well, it matters hugely. First and foremost, treatment planning. As we touched on, knowing if an organ is primarily serial or parallel directly dictates how you set your dose constraints.
Right. For a serial organ like the spinal cord or optic nerve, you are watching those maximum point doses like a hawk. You just cannot exceed certain thresholds, even in a tiny volume.
Exactly. Tolerance is very low for focal high doses. But for parallel organs, say the lung or kidney, while hotspots are never ideal, you're often more focused on metrics like the mean dose or those volume dose parameters like V20 for the lung or mean kidney dose.
Because you're managing the overall functional reserve, the total load on those independent subunits.
Precisely. It's about how much of the organ's total capacity you're impacting.
And then there's fractionation. We keep coming back to this, but it's so fundamental. That difference in alpha-beta ratios between early and late tissues.
It's the bedrock of modern radiotherapy, really. Late tissues generally have low alpha-beta ratios. This means they are disproportionately sensitive to the size of each radiation dose fraction compared to early tissues, which have high alpha-beta ratios.
So using smaller fractions spares them more.
Exactly. This is why conventional fractionation, using doses around 1.8 to 2 grays per day, works so well clinically. By giving those smaller daily doses, we exploit this biological difference. We spare the late-responding normal tissues relatively more than the early-responding tissues, and often more than the tumor itself, which frequently has a higher alpha-beta ratio.
Allowing us to get the total dose high enough to kill the tumor,
while keeping the risk of those severe, often irreversible late side effects within an acceptable range. If you jump to using very large fractions per dose, like in SBRT or radiosurgery,
you lose that differential sparing.
You dramatically increase the biological damage to those late-responding tissues for a given physical dose. That's why the dose constraints for organs like the spinal cord or brainstem or even bowel are so much tighter, so much more critical when you're using hypofractionation. You have less wiggle room.
That's such a critical point. Fractionation isn't just about clinic schedules. It's a biological tool we actively use to manipulate tissue response.
Absolutely. And looking ahead, understanding these mechanisms points towards potential ways to mitigate toxicity. We talked about fibrosis and TGF-beta.
Right, targeting that pathway seems like a logical approach.
It does. And TGF-beta has been a major therapeutic target for developing antifibrotic drugs for years, trying to prevent or lessen radiation-induced fibrosis. Honestly, clinical success has been pretty limited so far. It's proven really challenging, probably due to the complexity, the timing of intervention, maybe pathway redundancy, but it's still a major goal. And researchers are looking at other anti-inflammatory and antifibrotic agents too.
And what about managing those really severe acute reactions? Sometimes you hear about a cytokine storm.
Yeah, in some rare severe acute reactions, you might see an overwhelming inflammatory response, almost like a cytokine storm picture. Knowing the key players involved early on, like TNF-alpha, IL-1, IL-6, helps us understand what's driving that massive inflammation and guides how we might manage it, often using things like corticosteroids to try and dampen that excessive response.
So it's basic science informing everything from planning rules to potential future therapies and managing acute problems.
Exactly. Direct clinical implications at every single stage.
Okay, so let's try and crystallize this. Let's pull out a few clinical pearls, the kind of high-yield takeaways that are good to have right at the front of your mind, maybe especially if you're, prepping for boards or explaining risks to a patient.
Okay, sounds good. Clinical pearls, let's do it. Pearl number 1.
Pearl number 1. Functional subunit arrangement dictates volume effects. Serial organs, think spinal cord, small high-dose volume is bad. Parallel organs, think lung, kidney mean dose, and volume effects like V20 or V30 are the key things to watch.
Good one. Okay, pearl number 2. Early versus late tissue response difference, primarily driven by cell proliferation rate and turnover. Remember H-type versus F-type models. And critically, late tissues are more sensitive to fraction size because of their low alpha-beta ratio.
Pearl number 3, radiation-induced fibrosis. When you think fibrosis, you think
TGF-beta. It's the master cytokine driving that process by activating myofibroblasts and causing all that collagen deposition. Remember TGF-beta for fibrosis.
Got it. And finally, pearl number 4. While TGF-beta drives the late fibrosis, don't forget the early inflammatory instigators.
Right. TNF-alpha and IL-1, key pro-inflammatory cytokines involved in those acute reactions, but also contributing to the chronic inflammation that sets the stage for late effects.
Excellent. Serial parallel volume, early-late turnover and fraction size, TGF-beta for fibrosis, TNF-IL-1 for inflammation. Those seem like 4 really solid pillars.
Yeah, I think those capture the core concepts we've hit today pretty well.
All right, feeling sharp. Ready for a quick challenge? Let's do a quick board blitz. Just 4 questions hitting these topics.
Okay, let's do it. Fire away.
Question 1. Which of the following normal tissues is classically considered to have a serial arrangement of its functional subunits, making it particularly sensitive to high radiation doses delivered to even small volumes? Is it A, lung, B, liver, C, skin, or D, spinal cord?
That's got to be D, spinal cord. It's the classic textbook example of a serial organ where damage to a small part can have catastrophic consequences for the whole function downstream. The others have significant parallel components.
Correct. Okay, question 2. The pathogenesis of radiation-induced pulmonary fibrosis is primarily driven by the overproduction and sustained activity of which cytokine? A, IL-6, B, TNF-alpha, C, TGF-beta, or D, BFGF?
We just nailed this in the pearls. Fibrosis, think C, TGF-beta. That's the main driver of the collagen production.
Right again. Question 3. Early responding tissues, for example, intestinal mucosa or epidermis, differ from late responding tissues, like spinal cord or kidney, primarily in their cristin. A, intrinsic radiosensitivity, D0 of their stem cells. B, capacity for DNA double-strand break repair. C, rate of cell proliferation and turnover. Or D, dependence on vascular supply for oxygenation.
This goes back to the HVSF types. The fundamental difference dictating early versus late timing is C, the rate of cell proliferation and turnover, how fast those functional cells are replaced.
Perfect. Last one, question 4. Which of the following describes a key characteristic of the functional subunits in a tissue with parallel organization, like the kidney?
Yeah.
Damage to a single FSU typically results in failure of the entire organ. B, functional subunits are highly interconnected and dependent on each other. C, the organ can tolerate loss of a significant number of FSUs before clinical dysfunction is apparent. Or D, repopulation from adjacent FSUs is the primary mechanism of recovery.
Okay, parallel, like the chandelier lights. That means C is the answer. You have functional reserve. You can lose quite a few individual units, quite a few nephrons in the kidney example, before the overall organ function really starts to suffer clinically. A and B sound like serial organs, and D is more typical of recovery in early, rapidly dividing tissues.
Excellent. 4 for 4. Those examples really help tie these concepts together.
Good questions. So to kind of summarize where we've been today, we covered a lot of ground on normal tissue responses. We started right at the beginning with functional subunits and how their organization, serial or parallel, influences those critical volume effects. Spinal cord is serial, lung and kidney are largely parallel.
And we linked that structure to function, specifically the timing of response early versus late tissues, connecting it back to cell proliferation kinetics and those H-type and F-type models. And the big takeaway there, late tissues are more sensitive to fraction size, low alpha-beta.
Then we spent a good chunk of time on the pathogenesis of probably the most feared late effect, radiation-induced fibrosis. We emphasized that chronic inflammation is key, and the absolutely central role of TGF-beta in driving myofibroblast activation and all that excess collagen deposition leading to scar tissue.
But we didn't forget the other important pro-inflammatory cytokines like TNF-alpha and IL-1 that kick things off and contribute to the whole inflammatory cascade. Really grasping these mechanisms is just fundamental to planning safe and effective treatments. It's key to protecting our patients.
It truly is. Understanding the basic biological response, how the damage happens, how the tissues try to cope or fail to cope, gives us the framework for everything else.
Yeah.
But, the clinical reality is always complex, isn't it? And as we keep pushing radiotherapy, higher doses, fewer fractions, maybe more reirradiation cases, our understanding of these fundamental normal tissue responses becomes even more critical. How much stress can these tissues really take?
It really makes you think about that delicate balance we're constantly trying to strike in every single patient, every single plan. Risk versus benefit.
Exactly. And how maybe, just maybe, we can get better at predicting who's going to have problems or find better ways to protect those tissues. That's the ongoing challenge.